Good evening, everybody. Welcome to the fourth episode of Focal Point, presented by Aniridia North America. We are so glad to have you here. I am going to get us ready here to get started. There we go. All right. My name is Janelle Collins. I'm your host for tonight. I serve as the member at large on the board of directors of an ANA, and I live in Florida, in the United States with my husband and two children. My 16-year-old daughter has aniridia, so that's how I'm connected to the community. Our episode tonight is focused on the aniridic cornea. Our guest is Dr. John Freeman. Dr. Freeman is board certified by the American Board of Ophthalmology and specializes in cataract surgery and corneal disease. And he has quite a bio here that I'm going to read because I couldn't memorize it all that fast, everybody. So I'm going to just read it off to you so that you know who he is. Prior to receiving his medical degree, Dr. Freeman received his BA in English from Davidson College in North Carolina. He earned his medical degree from the University of Tennessee College of Medicine. He served his residency at the University of Tennessee Health Science Center, and he completed a cornea and external disease and refractive fellowship under Dr. Edward J. Holland at the University of Cincinnati College of Medicine. Many of you have heard that name before in the aniridia world. His fellowship included training in ocular surface reconstruction and advanced anterior segment surgery. Dr. Freeman has worked with aniridia patients for many years. First during his fellowship under Ed Holland, then in Memphis with Peter Netland. During this time, he was the first to characterize aniridic fibrosis syndrome. I just learned that a couple of years about you, Dr. Freeman. I thought that was really interesting. He's currently serving on ANA's new medical advisory board. He also serves as medical director of the Mid-South Eye Banks and on the board of the World Cataract Foundation and the Advancing Sight Network. He has recently retired from private practice, but continues to staff and teach residents for the VA and the University of Tennessee Ophthalmology Department, and is looking forward to staying involved in the care of and research for congenital aniridia corneal condition. Now, since I have met Dr. Freeman, but I've never had the privilege of seeing him as a patient, I asked one of his patients to tell me a little about him. And this was Carrie Carlisle's response. She said, I was a patient of Dr. Freeman's from the time that I was about 10 years old. He has taken really good care of me, along with all of his other patients. One thing that stuck out to me was that he's not only concerned with my eyes, but he was also always interested in everything else going on in my life. He would ask me questions about my service dog, my family, how work was going. To me, that's what makes a fantastic doctor, one that wants to know about all the aspects of their patients' lives. Dr. Freeman is honest, kind, hardworking, and he will be so dearly missed as he retires from private practice. So that was what Carrie had to say. Dr. Freeman, I'm so honored that you've joined us here tonight. Thank you.
Well, thank you. It's an honor to be here. It really is. Thank you.
Um, I want to say thank you to everybody who submitted questions ahead of time. I got a whole bunch of them. I have like 4 pages of questions here for us to go over. If you think of more questions as we talk, please feel free to ask them in the chat. We will do our best to answer as many as possible tonight. However, I do want to mention that the aniridic cornea is an extremely complex topic. I hope you are seeing my screen with an iceberg on it. And the reason I'm showing this is because what we see as patients when it comes to the cornea is really just the tip of the iceberg here. What happens to give us this clinical care really is much more deep and involved than most of us know. So tonight, Dr. Freeman and I plan to handle this tip of the iceberg. We're going to talk about an introduction to the cornea. We're going to talk about the anatomy. How does it work? How is it supposed to work? Some of that. We are not going to get in depth into clinical research, preclinical, that sort of thing. We are going to have multiple episodes actually related to the cornea. Right now, we're planning at least 2 more. We might even do a 3rd after that. We're not sure yet. But in those, we will handle things like clinical research and things that are coming up in the realm of treatment. So I just wanted to set that stage ahead of time to know that we aren't going to cover absolutely everything because there's way too much to cover with the cornea to do that in 1 hour. So this is just, like I said, the first in a multi-part series. So we're going to get started with some real practical introductory questions. And I'm going to start with this because it's almost weird to admit this now, but when my Ellie was diagnosed, 16 plus years ago, almost 17, my first thought when the doctor said to me, well, she doesn't have an iris, my first thought was, wait, the iris is the colored part, right? Like it had been years since I had taken a biology class or anything that talked about the eye, right? Um, and so a lot of times I think when new parents get this diagnosis, there's a lot of terms we don't know. So Dr. Freeman, can you do a quick refresher on basic eye anatomy for those who might be new to this?
Sure. And I won't necessarily share my screen, but I'll sort of use my hands a lot. But if you imagine the eye is like a camera. So it has a lens on the front and it has a retina or film in the back of it. And then the cornea is the front lens of the eye. And you have an internal lens, and that is what becomes a cataract later in your life. And that's what's behind the pupil. And the pupil is what gets bigger and larger. And in aniridia, the classic, finding is that you don't have much of a pupil at all. And this can be variable, but the pupil is not formed, and that's how it's diagnosed in large part. But also an important part, and to go back to the iris, when you're looking at somebody, you're looking through your clear cornea and you're looking through their clear cornea and seeing the color of their iris. So, if someone has a brown eye, you're seeing their brown iris through your cornea and through their cornea, and you couldn't see it if the cornea wasn't clear. Well, so aniridia comes with a problem with the iris, and that's what the term comes from. And then it also has nystagmus. So nystagmus is a classic finding, and this is related to the development of the visual system, and probably in large part with what's called foveal hypoplasia. And that just means the retina, which is the film of the camera, is not fully formed. And when the retina isn't fully formed, it's sort of like the brain is trying to track on something, but it doesn't have enough data to like steady itself. So it's sort of like a camera that's trying to focus on something and it's going, it's just sort of looking around. And we sort of think that's what, nystagmus in a sense is from. And so that would be the sort of classic, triad, which would be the foveal hypoplasia, which is an anatomic finding, which means the retina is not fully formed, the aniridia, which is the lack of iris, and then you have the nystagmus, which we think is probably related to the foveal hypoplasia.
Excellent, thank you. So you talked, about foveal hypoplasia. You talked about the iris. Can you talk a little bit about some of the other differences or ways that the eye anatomy itself is different? Or I guess how that would display itself as we go further in life, whether it's tear film or something along those lines.
Well, what's interesting is it's like you have a series of things that kind of went wrong or went off course or were not fully finished during development. And then you have things that happen afterwards. And that's one of the big things that's come from basic science research is that PAX6, which we know is the gene that's involved in most aniridia, has adult functions also. And so we think this is part of why the cornea starts to get keratopathy, which just means disease of the cornea. That's all it means. And so, but basically the big limitation from birth is the foveal hypoplasia, and it doesn't fully form. What's interesting is in a normal human infant, the fovea is not fully formed. They don't have their vision at birth, but it happens for those first, 6 months or 9 months of life. And that's where you kind of get your fine vision. And so in the beginning, things are kind of blurry, and the brain through this process of looking at the world interaction that does something to the brain. This happens during that first year of life. And this is one of the reasons. Let's say you have a perfectly normal eye and you put a patch on that eye, and they did these experiments with monkeys. If you deprive the visual system of things to see, you'll get what's called amblyopia. And so this is why you can, in non-aniridics, if you're born with an abnormal, a cataract, which is normally happens in late in life, but a cataract doesn't allow the retina to see anything. And we know that we need to get the earlier we can get the cataract out and get clear vision to the eye, the better the eye will see for the rest of its life. In a similar manner, and this isn't to do with aniridia, but if you have a problem with an eyelid, like sometimes there are eyelid, problems in development, and that eyelid won't stay up, well, that eye that's deprived, it won't develop fine vision, and so that can be a big deal to fix the eyelid. So there's an interaction between, the anatomy at birth, having good vision that happens to give you your fine vision. And we know that you have these anatomic problems that happen at birth, and then that it allows you not to develop normally. So
Right. Okay. So tell us more about the cornea. I think one time when I heard you speak, you talked about how this is literally a problem right in front of our eyes, right? Because that's what it is. It's right there. So how does a typical cornea function throughout a person's life? What would it
so
normally do?
yeah, it's really it's not super exciting. I'm going to try to share a screen with y'all here, and but the cornea, right? Let me see. Did that come up?
Yep, it's starting to come up.
Okay,
Here we go.
so if you look at the image on the right, that's the image of a normal cornea, kind of from the side, and the cornea is like a clear dome, like a bowl turned upside down that's clear, and it has basically three different levels. And on the outside is what's called the corneal epithelium, epi meaning outside, and it's the skin of the cornea. And then the most part, and this is interesting about the cornea is only about half a millimeter thick. So if you think, a millimeter is really tiny, half a millimeter thick is really tiny. And so it has an epithelium and an endothelium. And both these have to be functioning normally to have a totally clear living tissue. One thing that's interesting about this tissue is it's a living tissue. It doesn't have blood vessels in it. Most everything else in your body has blood vessels in it. The cornea does not. And so it's a half millimeter thick. You have an epithelium on the outside, endothelium on the inside. The main problem we think with aniridic keratopathy and to go back, normally you don't have problems most of your life. Most people live their whole cornea maintains itself, maintains good, and you don't need cornea transplants or anything like that. You have some diseases that do cause that, but for normal people, your cornea lasts you your whole life, stays clear your whole life. And what happens in the normal cornea is if you look at sort of the top picture there, you have a ring of what are called limbal stem cells around the normal cornea, and these provide the epithelial corneal cells. And it's like the skin of the cornea. And as you know, our skin is always reproducing new skin cells. And if you rub your hands together, some of your skin cells fall off. Well, your cornea apparently is always desquamating corneal epithelial cells all the time. And when a new one is made in the periphery where the limbal stem cells are, and then it goes into the center and then it's lost on average 21 days later. So every time you blink, you probably lose a few little corneal cells. And so throughout your whole life, your limbus, your corneal limbus, which is the ring around the cornea, it's not clear. It's the peripheral part is providing corneal epithelial cells that grow over the whole cornea and help keep it clear. What's interesting, we were talking about blood vessels. blood vessels grow up to that limbus. In fact, there are a lot of blood vessels there, and there's sort of like a network of blood vessels right at the periphery, and your cornea gets part of its oxygen for its cells from those blood vessels, and it also gets some of the oxygen from the air, actually.
Oh, fascinating. I did not realize that. That's cool. I mean, I guess I should have, but now that you say that, that's very cool. Now, how do our tears typically help our cornea?
So the tears are very important. So if you don't have tears, these are living cells, okay? And like your mouth, and so they're living cells. And if you just sort of think about how you grow cells in a petri dish, like in a lab or something like that, you're always having to put stuff on it. And living cells inside your body are usually bathed in stuff, that make them alive, and your skin is a particular type of cells that are becoming different as they get to the outside that protect you, and they're constantly being shed. The cornea is unique in that it's not as tough as the skin, and it's not keratinized. Like the skin has a bunch of keratin in, and that's sort of like waxy kind of stuff that protects your skin. Your cornea isn't keratinized. And in fact, if you don't have vitamin A, it starts to become keratinized, and it becomes like your regular skin, and then it gets scarred over, and you can't see. So the tears are constantly being produced from your lacrimal gland, and they have all sorts of stuff in it that nourish the tears. And you also have things, the conjunctiva, which is the white of your eyes. It has goblet cells in it that secretes also little chemical things that your cornea needs. And then also your eyelids, the edge of your eyelids secrete oils. So you have all these things in it. And if you look at tears, it's full of molecules that are necessary to maintain the cornea. And if you lost these, your cornea would become if you lose your tear film, you can't see clearly, and that's probably part of what's going on, in Aniridia is partly is the tears aren't quite as good.
Okay, so that's a great transition to how is it different in aniridia than your average cornea? And one person, Hannah from Hungary, actually asked, what causes this corneal epithelial cell deficiency?
So we we're still figuring out, like, it's sort of like a chicken, what came first, the chicken or the egg, but we think it's mainly a problem with maintenance of the corneal epithelium. So we remember that's the outside layer that, on average, a new corneal epithelial cell is produced at the corneal limbus and then is desquamated 21 days later. We know there's something that goes wrong with that process. If you have a chemical burn of the cornea, it will damage your limbal stem cells, and even if it was just on the surface, your cornea will become scarred and opacified because the corneal epithelial cells aren't good. There are conditions like people who used to wear old, fashioned contact lenses would damage their corneal limbal region, and then they would start to have scarring of the cornea. And Stevens-Johnson syndrome is a condition where the limbal stem cells in the ocular surface are damaged. So if you don't maintain a proper limbal region, and these are called the limbal stem cells, basically your cornea doesn't maintain its clarity. And you think, okay, well, why can't you do a cornea transplant? And this is probably one of the most important things to understand this whole night. So cornea transplants have been done for more than 100 years, and they're very successful typically because the cornea doesn't have blood vessels in it. Okay. But when you're doing in a normal situation and you're doing a cornea transplant, let's say you had a corneal scar from a corneal infection from wearing contact lenses that put a big scar in the middle, but everything else with the eye was healthy, especially the limbal stem cells. You could cut out the cornea in the central clear part and then take a donated cornea from a donor and sew that in place, and then it would be clear. to maintain the clarity, the host limbal stem cells start covering that cornea and keep it clear for the long run, for years afterwards. And so our understanding, and so if you have a chemical burn, you can't just do a cornea transplant because the host limbal stem cells aren't good. Okay.
Yeah.
And so you can put a cornea on and it comes with some epithelium frequently, and maybe for a month or two, and sometimes shorter, sometimes longer, it'll be clear, but it will slowly and gradually scar over because the limbal stem cells, which are supposed to be there giving corneal epithelial cells, aren't functioning. They're not, they're dead. Now you say, okay, why don't you transplant these? Okay, you can transplant these. But the problem is, remember we said they're blood vessels at the limbal stem cells? Those blood vessels mean you will reject the transplanted tissue just like you will for a kidney transplant or a liver transplant or other transplants. And Dr. Holland, he's the the biggest guy in the US, that was doing this for such a long time. And you basically use the systemic, meaning through the body immunosuppression, like you do for a kidney transplant. It's almost the identical drugs, and it may be something that gets tweaked. And that's the problem, is those drugs, can be rough on the body. It works, but they can be rough. It's an imperfect situation. So to kind of go over this just for again, cornea transplants, they work well in normal situations because the cornea doesn't have blood vessels in it. And if you're not worried about the limbal stem cells, if the host has good limbal stem cells, you do a cornea transplant and then you can use steroid drops and usually get them down to a low level of steroid drops or no drops actually in some cases. And the host body won't reject the donated tissue, which is not self.
Okay.
In Aniridia, it's a problem primarily with the stem cells. And we're still kind of figuring this out. There is some debate, but the stem cells we know are part of it. And Dr. Holland he beat this into me, so I got to make it clear. Dr. Holland's opinion, I believe this, doing cornea transplants for aniridic keratopathy are not indicated because you're not replacing the defective limbal stem cells. And sometimes they will work for a short time, but they'll slowly become scarred over.
So you've mentioned the word keratopathy, and you've talked about that it is a disease state. Um, and you've also mentioned the limbal stem cells. So are there other things also involved that are contributing besides the limbal stem cells, or is that something we're still very much researching?
This we're researching this, and we know that it's part of the problem. And this is what's to me very interesting about this, is that PAX6 is a gene that's conserved in evolution, and so biology says, okay, if you have a conserved gene, meaning it's in different species, like it's in a worm, a C. elegans worm, or it's in a Drosophila fruit fly, and then it's in a human being or a mouse, it is an important tool and I believe in God, that God used during evolution. And so, but it's also a tool that's used during the adult maintenance or during your lifetime. So nature or God says, well, this is such a useful molecule. We'll use it here. We'll use it here. We'll use it here. So and this is why we're hopeful that if we can replace it during the lifetime of a patient with aniridia, that we can slow down or halt or maybe reverse some of this degradation that we see during the course of the lifetime. Let me show you, let me see, can y'all see this picture?
Yes.
Okay, so so this is important thing. So initially, aniridics start with a clear cornea, and then during the lifetime, it kind of starts from the edge and then moves across the center. And we talk about that the foveal hypoplasia sets the baseline for the vision. And sometimes this is 20/50, almost normal. Sometimes the baseline is 2200. But when aniridic keratopathy happens, then it will drop the vision from baseline. And if we could just fix the cornea, we could get patients back to baseline. And we're not, other things that drop your vision are glaucoma and cataracts, but we're not talking about those. But those sort of have conventional therapies for them, and the cornea doesn't have conventional therapies. Um, if you look at this slide,
That
you
was
see,
actually my next question is the rate of
okay,
occurrence. So there
yeah.
you go. You're ahead of me.
So, all the time, if we are seeing a 6-year-old or 8-year-old, we wouldn't see aniridic keratopathy. The other thing is it can be hard to see in a baby, okay? And there's something called late staining, and I have a little video. I don't know how it would come across, but if you look at this little graph here, it says, when you're 5, only about 10% of patients have it, and by the time people are about 25, it's up to 50%. And this is very variable. So this doesn't hold for everybody, but on average. And so this is a condition that comes on usually after the teenage years when it starts to really hit people and dropping their vision from baseline.
Okay. Um, are you familiar with, is there any indication that there's a difference in the condition of the cornea depending on which genes are causing aniridia or maybe even the specific mutation or
Yeah,
deletion?
I don't know. We
Okay.
I'm not familiar with it, because there are, some non-PAX6 genes
Mhm.
that can cause aniridia, and I do believe there are some papers that look at what that would be the genotype phenotype correlation, but I'm not sure of strong you
Correlations
know,
on that yet.
visions that you can make doing that.
Okay.
One thing that I will, while we're mentioning about genotypes, is I do think it's important to get the genotype for what you have or what your child has, because therapies are coming out that potentially can impact your genotype. This adalurin therapy, which is a PTC pre-termination codon, well, apparently about 50% of the PAX6 gene mutations are PTC premature termination codons. And so as more research is being done on this and it says, oh, this works, then you would know whether it might benefit you. And we are starting to become in the era where we're seeing genetic uh, uh, diseases being treated by understanding the genotype and having solutions. So I do
Absolutely.
think it's going to happen. It's just slower than you want it to be.
Well, right. We'd like it, yesterday,
Yeah,
but
exactly.
we'll
Yeah.
take it if we can get it here soon. And so, yes, having your specific mutation is super helpful. Um, so let's start with maybe some prevention talk first. So, is there any particular treatment or preventative procedure you can give for a 3-month-old baby? And I got this question from like 5 different people. So,
Yeah, we really don't have we what we're trying to do is extrapolate just conventional therapies, and so we're really in a sense in the stone age of treatment in it, and just trying to come up with things. We basically think that the corneal epithelium in aniridics is more fragile, and it's sort of more delicate, and so you try to do things like I think someone had asked, like, would be swimming in a chlorine pool be a bad idea? When I was a teenager, I used to swim with my eyes open in heavily chlorinated pools, and I can remember coming out at night and seeing little halos around things, and that was part of and I think that would really be bad for an aniridic. Because that you're doing an insult, and one way of thinking about this is probably aniridics don't have the reserve in their limbal stem cells or the maintenance of their cornea. So if you do anything that can kind of help hang on to the maintenance of their cornea, like I would say, I wouldn't want you to be sitting with a fan blowing on you strongly, uh, you know, that where your eyes were tearing and watering, your eyes water, when you're cutting an onion because your eyes are sensing the noxious thing and your eyes doing whatever it can to protect itself. And so a heavy wind of fan blowing on your face makes your eyes water because it's trying to protect itself. You wouldn't want you like I wouldn't say like if you have Aniridia, don't be the one who cuts the onions all the time. And I
Okay.
know that sounds trivial, but it's that sort of thinking. If you're using tears, preservative free is probably better because we know that the preservatives in normal corneas can cause some damage over time. And we also know that even sometimes in the preservative free solutions, and this is why it's so confusing, they add these different things, and it may be that and we know that some of the little things they have added to the preservative free tiers, some people are sensitive to. And so if they take this certain brand, their eyes get red and because they're sensitive to what they have added to it. And it's sort of like thickening agents or something like that. And so it's but typically you would try to protect the eyes and be gentle on the eyes. And like if they're putting them on glaucoma drops, I would say always try to use preservative free glaucoma drops. I would say use goggles when you're swimming in a pool. When you're out in the wind and the sun, try to wear a hat and sunglasses. I think are a great idea. End in the sun off the eyes. And a lot of times aniridics are kind of sensitive to the wind and the sun anyway, and it's because they can tell it's harder for them, and that can be also because the iris isn't there. But there's no tried and true. I've always used in my ophthalmology career autologous serum, which are drops made from your own blood, and we don't have great data. It's at that kind of crude level of research, but there is some data that in aniridics autologous serum did help them, and it didn't reverse the disease but made their symptoms better.
Okay.
And so, I think autologous serum has growth factors and vitamins from the patient's own blood, and you mix it with preservative-free tears. And I think it's likely beneficial, but it's not like strong proof and like everybody should be on it. But if I had a child, I would probably put them on autologous serum.
Okay.
So
Okay. That's actually one of my questions that I hadn't put on my list, but I wanted to ask you was, if you had a child with aniridia, what would you do?
yeah.
And that obviously is one of them. So that's great. Um, should we be, now this is something I also asked Dr. Levin, but I always like to hear it both from a pediatric perspective and from a corneal doctor. Should we be more concerned about like pink eye than we would be in a typical child, or not a big deal?
I mean, one thing is pink eye usually clears on its own, and just using tears. And like there's some people who would go, if you get a cold, it's a viral infection and your eyes get pink, and so that's pink eye. And pink eye just means pink eye. And some people like, oh, I got pink eye, I need to go get an antibiotic. And pink eye that doesn't clear in a few days or it's not associated with a cold, sometimes you do have to worry about it, but only in those situations. And there's some pink eye that sometimes that drives you to the doctor because it doesn't get better and you need some steroids, you need some antibiotics or something. But usually, I don't think you need to worry about it a lot more in an
Yeah.
aniridic. But one thing I would say is don't be too hyper about it either. But like if their eyes are getting really gooey and stuck together and pus is coming out, then I'd probably go see it and see eye care professional. So
Okay. Should we be more concerned about any kind of scratch on the cornea or something like that than a typical patient?
well, and that's what the way yes, and that's one of the things because it's like another insult, and so you're using up the reserve. And this, superficial keratectomy, which is scraping off, scratch is scraping off the corneal epithelium. A superficial keratectomy that sometimes can be a treatment for scars of the cornea are done when you think the limbal stem cells will grow back better than what was there before. So this is one of the areas where most people say that won't work in aniridic keratopathy, or I'm of the opinion it's unlikely to work. Now, if you could scrape off the diseased epithelium and give some special solution that would make new epithelium grow that was healthy, then that could be a solution. And but a scratch, yeah, avoid scratches as best you can. And when you have a scratch, it can get infected, and so typically we think you should be on antibiotic drops until it heals.
Okay.
So,
So David from Michigan asked, what changes should we be on the lookout for with like younger children or teens to know if we're beginning to experience corneal issues?
well, to me, it would be light sensitivity that's getting worse, probably. Eyes getting more red, uh, eyes tearing more, and just more complaints. Photophobia is light sensitivity, and I would suspect most analytics would have sort of a baseline and then that getting worse. Also, the recurrent erosions are something that can happen. And a recurrent erosion is like a scratch in the cornea, but nothing scratched it. And there's the way I'm going to describe it isn't exactly what happens, but there's actually truth to it. It's a recurrent erosion is almost like your eyelids get stuck to your cornea, and when you open your eyes, a little part of your cornea peels off,
Ooh,
and that's kind of we think that's kind of like a recurrent erosion.
okay.
And so, like, if your child was waking up and really in pain when they woke up. Now, having said this, let's go back to environmental things, because this makes me think, okay, especially for people living in the north, when it's really cold and your heaters are running, you should look at the humidity where you are. In the South, we don't have humidifiers on our central units, but up in like Chicago or Canada, a lot of times you'll have a humidifier because you know what that low humidity does. And so low humidity makes it more likely to have dry eyes and also brings out recurrent erosions. And so, like a classic setup scenario would be, oh, I had a cold last night. I took some Benadryl, which dries out secretions, and then the heater was running just to keep it, at 55 or whatever, 60, and the humidity was very low. I dried myself out with the Benadryl. The environment was dry, and then I had a recurrent erosion the next morning. And so a humidif keep the humidity in a kind of that middle range, 40 to 50%. And definitely when the humidity is low, that can be an insult to the cornea. One time I went out to Colorado where we had a wedding at a high altitude, and the humidity was so low, and I was trying to read my iPad and my eyes were just watering because it could sense the dryness. So a humidifier can be something especially during the winter. And this is in dry eyes, the general way I think about it in the winter is where a humidifier will help because our heaters are driving the humidity down. And so getting a hydrostat or a humidity meter that shows you what the humidity is, you'll learn what it is where you live. And when it gets really low, and typically I'd say below 35% is where a humidifier will help. In the summer, when our fans and air conditioners are blowing and the air conditioner is trying to keep the humidity below 50%, that's where you just have to protect yourself from air movement. And this sounds crazy, but wearing a baseball cap inside keeps air movement off your face. And there are a
Oh,
lot of dry eye patients that just wear a baseball cap and it just keeps the air from moving over their face and they feel better. So that can be a little
that's
tip too.
that's a fairly simple tip
Yeah,
that
it's
could
simple,
help
simple,
immensely
but
if you're struggling with
yeah.
dry eye. That's brilliant. So I had a bunch of people ask, all right, what is the recommended treatment when your keratopathy gets bad?
Okay, there's not a definite recommended treatment, and this is really difficult, and and I'm kind of a worrier type personality, so if it was my kid, I don't know what I would do. And the way, and this is, and I realize some of my approach to it is probably getting not, cutting edge in a sense because my training was 20 years ago, but I still think this is the basic choices, I think. So until we get something better. So the a normal cornea transplant won't work. It may work for a short time, and you can do a limbal stem cell transplant, which also has problems with it, mainly the systemic immunosuppression. And it can work, but we also know in aniridics they don't work quite as well as some other categories of people who need limbal stem cell transplants. And we think that's probably because the ongoing maintenance that goes on with the PAC6, but they do work to some degree, but you have the risk of systemic immunosuppression. If you are a very sophisticated patient with a sophisticated healthcare system that's checking all the labs and doing everything, it can be a good way to go. But you can have these secondary consequences that are the result of being immunosuppressed. And the limbal stem cell transplant probably won't last forever. And like if you got 10 years out of it, that would be great. And you might need another one in 10 years. And every time you have a transplant, it's a little bit like vaccinating you against the next one, just a little bit, because every time you show a body other than self, it sort of like primes the body to react to
Okay.
that self. If we could just grow our own organs and put them back on ourselves, we wouldn't have that problem. So,
Right?
but
No,
we,
that'd be a bonus,
that'd be
right?
awesome. All right. Then and so limbal stem cell transplant with a cornea transplant is one way to go. The other way to go is an artificial cornea, and this is what I think would really, there are some artificial corneas that are in the pipeline that hopefully will be better, and this would be fantastic. And the great thing about an artificial cornea is that your vision comes back almost instantaneously.
Mhm.
Like I've done some artificial corneas, the Boston keratoprosthetic, on a patient that was totally opacified. And literally the next day when we took off the patch, they were 20/20. I mean, and
Wow.
these people had normal back of the eye, but it would return people to baseline. The big problem with artificial corneas is you're connecting the outside non-sterile world and you have an optic to the inside totally sterile world. And it's like the bacteria can get in where the tissue kind of breaks down. And if we and it seems crazy, but we haven't developed the perfect artificial cornea yet. And I have some Aniridic patients that I've done a K Pro on, and they're doing fine. But also next month they couldn't be doing fine, and that's the problem. You can have a catastrophic sudden loss with an infection. And if you get on it, you can save the eye and live to fight another day. And once again, it takes not, and I don't mean sophisticated patient, but a patient who's paying attention, who listens to the guidelines, does all the medicines, and then sees the doctor regularly. And the artificial corneas can do well, but both these pathways have risk, and both require attention to detail by the clinicians and by the patient, and they're both imperfect. And if we had the perfect way to go, we'd be telling you this is what you do, but we don't have
Right.
that
Right.
yet.
Now, there are some times, I mean, I've met a few where we have babies who need a corneal transplant, even in Aniridia. Now, it's rare, but
Yep,
sometimes they're born with a completely clouded cornea.
yep,
Obviously, at that age, we don't do a stem cell transplant, right?
yep, yep.
And if we don't do the corneal transplant, then the brain vision that you were talking about earlier can't happen, right? So I assume in that case, they do the corneal transplant if it's that bad.
Yeah, and so and I haven't done this for years because in cornea specialists they say it's the crazy young cornea specialist that will do pediatric cornea, but it can be really important, and it's because I'm going to tell you two stories. Okay, there was one patient. So, and I don't think she'd mind my sharing the details. I won't give her name, but she was born with a form of Peters anomaly, which
Mhm.
is a dysgenesis of the front of the eye. It's a problem with, and this is when Peter Netlin was in town. And when you have someone like Peter Netlin, we would, go into battle. She also had glaucoma and she had cataracts and she had opacified corneas.
Okay.
So we did cornea transplants and we also did Ahmed valves, which some of y'all may
Sure.
know that's a treatment for glaucoma. Well, the cornea transplants failed in less than a year. And it wasn't necessarily because of stem cell transplants, but just in pediatric cornea, I'm sorry, it wasn't necessarily because of stem cells that were bad, but pediatric cornea, the body rejects just tremendously, even if you're on steroids.
Okay.
So we talked to the family and we decided to do Boston keratoprosthetics, and we did one in one eye and we did one in the other eye. And till she was about, and this was when she was less than 1.5 years old.
Wow.
Okay. And this took a lot to do, and we were seeing her regularly, and she did well till she's. I may get the years wrong, but long story short, one eye about 8 years later started to have had a retinal detachment
Oh no.
and turned into an inoperable retinal detachment after several tries of fixing it. And basically, she lost vision in that eye.
Yeah.
Okay. The other eye is still going strong, and she's starting college now. And so
Very cool.
this is, so in this two N of two eyes, one eye was lost and then one eye was saved. Now that eye, she can, and she wants to be a astronomer, and she's going to college and she's learning about astrophysics, and she's really it's a wonderful story, and it does make me almost cry to know that if we had just left her the way she is, she couldn't. She can read her iPad if she holds it up close. She has about 20/80 vision,
Okay.
and she can, and she's gone to Arkansas School of the Blind and learned how to adapt to that. But she still has this artificial cornea, and she still needs to be seen by a glaucoma specialist and a cornea specialist. And something can happen in her that is, where she could lose that eye. But she has, seen some more than she would have had we not intervened.
Yes.
And what would be great is if some point we get a better artificial cornea and can put a new one in. And just to do the surgery would be some risk to that one eye she has. And so
Right.
that will still be a difficult decision. And so if we had not done anything, maybe in 3 years from now, we'll have a great artificial cornea, and that would have been the solution, but her eye wouldn't have developed during these past years. So this is the difficulty. There was
Yeah. Joe,
another,
Joe just
oh,
said in the chat, it's such a tough balancing act of the do no harm, but how do we improve it? Where's that balance? And it's a tough balance with the cornea, especially
yeah,
in Aniridia.
yeah. I'll tell you another story was a patient from up at St. Louis that had a K Pro, and he had some type of anterior segment dysgenesis, and one eye hadn't developed at all.
Hmm.
And he had one eye that someone else had done a K Pro on. I think, yeah, I may be getting things mixed up, but had done a K Pro on. And what a K Pro is a keratoprosthetic. Sorry, keratoprosthetic. And the most
Artificial
common,
cornea.
yeah, artificial cornea. And the most commonly one is called a Boston K Pro or Boston keratoprosthetic, and it's the most common one. But this patient had a K Pro, and we did another K Pro, and no one, it was in another part of the country, and no one was around to take care of it. So they came to Memphis to take care of it. We did another K Pro. That one started to go downhill. And so we had to take that K Pro out and do a regular cornea transplant just to save the eye. And it was like his tissue was melting. He's having scar tissue. And that was where we were trying to make things better. And we never figured out what his developmental disorder was. It wasn't
Okay.
aniridic, but we were fighting to try to give him vision, and that ended up in a blind eye.
Okay.
And so it's an eye that would have maybe seen hand motion, and there were times where we gave him better vision, but within 2 to 3 years, he lost his eye. And
Okay.
that's sad because you it's so imperfect. It's so tough.
We just don't know. You know, what I've always heard the K Pro described at is it's amazing when it works,
Yes, yep,
and
yep,
that a large percentage of the time it works.
yep,
But when
yep,
it doesn't, it's a major, major catastrophe. So,
yep.
like there, that it makes it tough. So I've got a couple of more like specific questions to ask you. And believe it or not, we are almost out of time. We've only got about 7 minutes left because we've been just chatting. So one, Kelly from Texas asked, doctor has prescribed short-term steroid drops for corneal swelling. Is this harmful? Is this okay? What would be your thoughts, obviously, without seeing the specific case?
Yeah, so steroids can be very they can be helpful. The big thing ophthalmologists think about steroids is that if you overdo them for long enough, it can give you glaucoma. And
Okay.
so glaucoma and also cornea swelling may mean something else is going on besides the normal aniridic keratopathy. There may be a failure of the endothelial cells, which we haven't really talked about much. So that those are what lead to the swelling. But the so that may be a sign something else in a sense is going downhill. And sometimes if the patient has had some surgeries, that can do some damage to these endothelial cells. High pressure can do damage to these endothelial cells. So there are all
Okay.
sorts of various things. So just make sure you're going and being seen regularly. And if it's an infant, this is one of the hard things is you need EUAs, you need exam under anesthesia to get a good exam and to get eye pressure sometimes. And this is one of those balancing things where you try to get what you need as far as clinical information to make decisions without, putting them to sleep every month. So,
Okay. So if you have a newly diagnosed infant, Adrienne from Maryland asked this, what type of exam is needed to like diagnose and check out the cornea? Or would that be handled in a normal exam with an ophthalmologist?
so at some point, it's best to get an exam under anesthesia. And what would be great is it's really good to have a pediatric ophthalmologist who can work with a cornea specialist. And see, this is a problem. We're just running around, trying to make ends meet to get those people together, but try to go to center where the people who are familiar with it, because you want to get a good pressure. And going back, the big thing that can cause irreversible damage is glaucoma damage. So glaucoma damage. So if your pressure is too high for too long, it will damage your optic nerve, and then there's a lot of research being done on this for all sorts of reasons, not just aniridia, but we can't make it. It's sort of like a stroke. It's really hard to, give people a new part of their brain. The optic nerve's kind of the same way. And so glaucoma and to, people who've had their eye pressure checked, you kind of have to hold still, and there's an air
Right.
cuff method, there's different methods. But in a baby, there is this little device
The eye
that
care. Yeah.
I care, but getting it at least during one EUA and maybe once a year for a while, and ideally it would be easy to do this and you could really monitor it, but it's balancing, how you can get it done. So
Right. So for most, in most cases with aniridia, the
yeah,
cornea is not going to be a huge risk when they're first born. And if it is, it's going to be very obvious usually. Would
that's right.
you,
Yeah, that's
usually
right.
that's pretty clear.
Yeah,
Whereas the glaucoma is the big risk when they're first, when they're little.
yeah, and I wish I could show you. I have this. Um, I have this little video. I bet it won't come across well on this, but it shows you it is an infant with an nystagmus, and I'm just holding an iPhone up to it, and you can kind of and you can see the aniridic keratopathy as it's going back and forth,
Interesting.
interrupting the red reflex, and you can kind of tell it's that pannus, which is kind
Okay.
of interesting. Yeah. So
That's
there's
fascinating.
yeah, yeah.
Okay. Just a couple more, because I only have 3 minutes left, so we'll have to be fast.
Sure.
If you have a 9-year-old patient, if the cornea has been damaged from a glaucoma preventing treatment, what can you do? Like scleral lenses? Is there like what would you?
So it depends. Glaucoma treatment sometimes damages the endothelium, and we have transplants for that. There are things called DMEX, DSEX, and you can transplant the endothelium. In a 9-year-old, it's harder. And when we say, oh yeah, you can do a transplant, 9-year-old, it's harder. And things scar more. Every time you do it, even with a normal patient, you can't have 10 cornea transplants. I mean, maybe you could, but each time you do it, you get a little scar tissue. And that aniridic fibrosis syndrome, every time you do a surgery, sometimes you get more scarring.
Right.
But the glaucoma procedure could have damaged the epithelium, the stem cells, or the endothelium.
Okay. Um, uh, Two more questions. One quick one. Patty from Florida asked, what doctors would you recommend somebody see for extreme keratopathy? Do you have anybody that you know of that's doing cutting edge work with that?
I mean, Dr. DeJillian and Dr. Holland and those are the main ones I know. Peter Netland over in Virginia, he had a cornea specialist he was working with there, and I don't have the name off the top of my head.
Dr. Chung, I think is his name that he's
Okay,
working with now.
okay.
So yeah,
So, and the problem is, you know, once there is some really great treatment, it's people aren't going to hold on to it and say, yeah, no, they're going to be so proud and this, I hope in my lifetime I can just be one little part of something that improves the treatment of this because I really think the potential's there, but we haven't got anything yet. you
right.
know, at the last, when I was at the meeting in Virginia with Peter Netland,
Mhm.
they were really talking about how they thought steroids could help. And once you have the glaucoma controlled, steroids, chronic steroids, may really help, prevent some of the scarring too. So,
Okay. So my last question for you is if it was your child and your child was in their 20s, let's say, and they had extreme, aniridic keratopathy, would you lean more towards let's take care of it now with one of these things that are imperfect? Or would you potentially lean more towards, let's focus on functioning well as a blind person for right now, and let's let some of these new treatments that are coming up, let's just protect the health of the eye and work towards these new treatments instead and wait for what's coming around the bend.
yeah, first of all, if they're in their 20s, I'd be talking to them a lot and
Right.
really finding out what they want to do. But I would also say, okay, if you're going to have one of the surgeries now, we always think about surgery, you can't take it back.
Right.
Medical treatments you can stop, but a surgery you can't take back is say we're only doing one eye and we're leaving one eye in reserve. And and see what they can what they can function with and what their ideas are for how they want to live life. Because this girl I was talking about from Arkansas, she I think she's probably glad she did this, and she has a very good attitude, and she knows that it can be lost at this stage,
Right.
but it's given her something that she wouldn't have had otherwise. And so it's a really difficult decision. And if I were probably going to do it, if it were me myself, I would probably go with one eye with an artificial cornea, and I would make my doctor see me like once a month or every 2 weeks. And every little thing I felt, I'd just go and say, look at it," and I would be, and that's how I would do it if I were doing it myself. And I just do one eye, and then just hope one of these better treatments come out. So.
Right. Okay. That's all the time we have for questions tonight, but I do want to tell everybody to please stay tuned for part two of our corneal series. Right now it's scheduled for April 3rd. We're still working for the timing on that, but that will be with Dr. Albert Chung. He works with Peter Netland at EVMS, and he will be talking a lot about the current treatments, but talking more about like what's on the horizon, what future treatments do we have that can bring us hope to be a little less scary, really, about some of that than what we were talking about tonight. And then we will have a third one actually with Dr. DeJillian sometime in May, and he'll be talking more about research. What is the current status of research? What are some of the I think there's, I don't know, 8, 10, 12, 15 different ways that they are trying to attack this problem in research right now. And so we'll let Dr. DeJillian, answer some of that too, to try to give us, again, a little bit more hope about what's going to happen in the future with the corneal situation. A recording of this episode will be available on the ANA website and the YouTube channel soon as we can get it up there. Be sure to sign up for ANA newsletters if you haven't already on the ANA website, because then you'll get a newsletter saying when it's ready. But before we leave, I would love it if everybody would turn on their cameras. I have to make sure that that's fixed so that you can do that. Hold on just a minute. So if you want to go ahead and turn on your cameras, because we always like to just say hi to everybody who's out there. And I'm going to remove our spotlights, Dr. Freeman, so that we can see everybody here. Because it's always fun to see all of these people that have joined us.
Hey, Peter.
Yeah, I was going to say, Dr. Natland, you're welcome. Oh, here, I think you can unmute yourself. Let me make sure. If you want to do so, say hi to some of our friends here.
Hi, Grayson.
Oh, I didn't even see Grayson come in. Hi, Grayson. Hi, Grace. Molly, Rex. Oh, it's good to see so many of you. Hi, Susan. Justin, how are you? Heather.
Hey,
Hey,
Grayson,
you.
you went to UVA, right?
I did. Yeah.
Okay, so your mom, when I met her up there, was trying to get my son to go to UVA, but my daughter ended up going to UVA, and she was very happy with it. So
Yeah, she's a good recruiter for the
okay,
entire
yeah,
entire school.
and we loved visiting her. So
Thank you.
Well, you guys, it is really good to see all of you. And like I said, we will be continuing this conversation because there is a lot to discuss yet in the realm of treatments and in the realm of research and all of that. There's a lot of hope on the horizon here in the coming years. And so we'll be hitting that hard in the next few. But it was wonderful to see all of you, and we'll look forward to seeing you hopefully again in a few months. So, and Dr. Freeman, thank you so much for joining
you're
us.
so
We really
welcome.
appreciate it. I'm going to leave this open for a minute in case anybody wants to write anything in the chat or just continue waving at each other, whatever you want to do. I'll leave that open and then we'll turn it off here in a little bit.